Hello, everyone, and welcome to this special webinar event, Beyond Fellowship, Career Paths in Advanced Bronchoscopy and Interventional Pulmonology. Tonight's webinar is hosted by the SAB's Education and Program Committee. Before we get started, just a few reminders for anyone new to our webinars. Everyone is currently in a listen-only mode and muted. Please submit all your questions into the question feature. It is located on your control panel. You also may raise your hand during this webinar and ask your question, and we will grant you access to your microphone. At this time, I will hand it over to Dr. Danish Ahmad, who will be moderating tonight's session. He is the SAB Education and Program Committee Chair. Dr. Ahmad?
Hi all, welcome again. We are very excited for you to be joining us for this inaugural Beyond Fellowship session, Career Paths in Advanced Bronchoscopy and Interventional Pulmonology. The entire group is very excited to have the chance to share our thoughts and speak with you guys about what questions you may have and how you are envisioning your path forward in your career. I am the Education Committee Chair. My name is Danish Ahmad, and I also work as an interventional pulmonologist at Fox Chase Cancer Center in Philadelphia, Pennsylvania. I'll have the rest of the group introduce themselves in a minute. I did want to make note that Dr. Vritti Gupta, who is one of the other faculty members on this webinar, is busy with a clinical patient right now, but she'll be with us shortly, and we look forward to her joining us. Thank you. Dr. Bawaadam, why don't you start?
Thank you, Danish, and thank you, SAB, for this opportunity to present at this wonderful and exciting talk of Beyond Fellowship. Myself, Hasnain Bawaadam, I'm a board-certified interventional pulmonologist working at the Advocate Aurora Healthcare Facility in Kenosha, Wisconsin. I'm currently the only interventional pulmonologist at this place and will soon be joined by a graduating IP faculty from Chicagoland area.
Hi everyone, this is Husam Nayef. I'm currently a Chief Fellow in Pulmonary Critical Care at Ascension St. John Hospital in Detroit, Michigan, and happy to join in this excellent team.
Hi everyone, I'm Sevak Keshishyan. I'm a practicing pulmonary and critical care attending. I graduated like 2008. After that, I worked as a pulmonary critical care attending, and then I decided to do interventional pulmonary fellowship, which I'm going to start in this July at University of Minnesota. So I'm glad to be here, and thank you guys for this opportunity.
Well, now that we have made the introductions, I think we'll just get rolling. I think the way we will format this webinar will be, we'll start with some discussion questions for the entire panel, and after a few discussion questions, I will have the webinar be open for everyone to ask questions. The ability to ask questions, if you guys can see the question dialog box in the GoToWebinar software, you can always place your questions in there. If you are able to raise your hands, feel free to raise your hands, and Emily should be able to get to you. But I think the best way would be to actually type in a question in the question box, and we'll get started. So seeing Dr. Nayef, that you're a current fellow right now and the closest to our audience, as well as Dr. Keshishyan, as you will be becoming an IP fellow, my first question was for you. I wanted to get insights from both of you about what led you guys to make the decision, one, to leave pulmonary critical care practice and enter into an interventional pulmonology fellowship, and Dr. Nayef, what factors you considered when you decided to pursue advanced bronchoscopy and take a faculty position.
Excellent.
Okay, go ahead.
I'll give the mic to Sevak. Take on this
Okay.
very...
Okay, so
I think you may be muted, Dr. Keshishyan.
Can you hear me? Yes. Okay. I think so. Everyone's decision, being an interventional pulmonologist or advanced bronchoscopist or proceduralist, I think it's personal. I have my personal reasons, and does not necessarily mean that everyone is going to have the same like of thinking what they want to do in their career. So my decision was based on my background. So I just want to say that I was trained thoracic surgeon in Armenia, and doing the procedures was kind of my way doing things. And coming to US, I always wanted in my mind that I need to do the advanced procedures. And after the fellowship, I started to practice as a attending critical pulmonary, and I felt that even doing some advanced procedures like navigational bronchoscopy or endobronchial ultrasound guided lethal biopsy, some chest, like some pleural procedures, I felt that I still need to do more. And there is a lot there that I need to learn. For example, like robotic bronchoscopy or medical pleuroscopy and all these new technologies. I think that was the main reason that kind of uh, pushed me to do another like a training in interventional pulmonology. Again, I know that for some other faculties and other like practitioners is going to be different, and it depends what you do in your career, what you do currently, what you do in your workplace. If you are working in a place in a tertiary center as a pulmonary critical care attending and you have a colleague that they do all the procedures in advanced bronchoscopy, maybe you can learn from them and have a guidance and go without doing like dedicated 1 year of fellowship. But for me, it was different. So last 5 years, I worked in a small community hospital, and I know that some of you guys you are intervention like international medical graduate. I worked because I wanted to get like a J1 waiver, and these small community hospitals, it's very hard to practice as an advanced bronchoscopist or proceduralist because uh, you are only one and you don't have resources, you don't have equipment, and you need that extra year of training to get confident what you want to do. I think that was the main thing that I want to learn. I want to dedicate another year of my life to learn these advanced procedures. So, Husam, if you, I think your position is going to be a little bit different, but I think that that's my way of thinking now.
Awesome. Well said, sir. I mean, I think your background, is very unique, and that's honestly, an excellent career path, because I feel like the non-invasive medicine is kind of like the future. So, and then we see this every day. From my end, it was a pretty tough decision. I think everyone here on the panelists and most of the audience probably are proceduralist people. So we all like procedures. We all want to be in the endoscopy suite and doing things. And I'm sure for most of pulmonary critical care fellows, it is a tough decision because you have to take in consideration what is your career trajectory, because you are doing pulmonary and critical care, and that's a 3-year fellowship. And if you are very passionate about it, and it's something you like to grow academically or non-academically, it will be affected by sort of the career path. And I think that's sort of what made the decision for me to not pursue an IP fellowship training was, in addition to being fortunate to have an interventional pulmonologist in my training who had spent a lot of time with me, and I profited from that. I don't have any IP fellows, so I'm the first person that he calls, and gets to do all the stuff, and I got the exposure that I wanted. So I had my shares of therapeutic procedures and diagnostic procedures, and I think it helped me a lot going to centers that they offer interventional pulmonology fellowship to really know what the feel of being an IP fellow is, and I think, or an IP attending. And I think, Vritti and Hasnain and Danish will speak more about the real life and what are the challenges that they had to go through. But I think from making a decision standpoint, if you're at a place where interventional pulmonology is being offered or delivered, you already know what it is. You already know what the practice is and what the procedures are. If you don't, and then you want to, let's say, do a certain amount of procedures, I encourage you to try and get to a place where they offer this, so you know if it's for you or not. You may like aspects of it and you may not like aspects of it. And I think that's how you delineate that fine line between being an interventional pulmonologist and an advanced bronchoscopist. I guess I'll speak a little bit more about advanced bronchoscopy for the audience members that are not familiar with what that terminology means. I think if maybe one word will probably draw the line is between therapeutic bronchoscopy would be the one factor that most advanced bronchoscopists, even if they have done those procedures, would not be comfortable really taking on those patients without a formal training or formal fellowship. And at least that's in the United States. I mean, in Europe, things are very different. So we're talking purely in the United States. So the rest of the interventional procedures would be, diagnostic bronchoscopy, including navigation in all form of platforms, EMN, electromagnetic or robotic assisted with shape sensing technology, and EBUS, and a variety of other procedures that kind of intersect. And we talk about, the world of cryobiopsy and its application in interstitial lung disease. And then those remain gray areas, because the question is, are you able to do the procedure? For the most part, you are. But the question is, when things get dicey, would you want somebody who's have more capabilities like rigid bronchoscopy and doing laser and stuff? So it really, I think those are more gray. But obviously, the biggest part of procedural bronchoscopy would be, at this point of time and career, would be BLVR, or bronchoscopic volume reduction. And the reality is, even the pioneers in the field, some of them are not interventional trained, and there are advanced bronchoscopists. So we have Dr. Gupta here. She joined us. Well, thank you so much for coming, because I wanted I was kind of talking about the early career choice of an advanced bronchoscopy, and I guess we'll give the mic back to Danish so he can ask more questions.
I think that was great, Dr. Nayef and Dr. Keshishyan. I think you guys did a great job of kind of delineating what was personally important to you guys, and I think we should always stress that. You really have to, as a fellow, think about what you want, not only from your career, but also out of your life. And when you think about your career, you want to think about in what location you would be envisioning your future practice. Is it a big academic institution? Is it a tertiary center? Is it a primary community practice where you're envisioning practicing? Because those things really do matter with regards to whether you want to do interventional pulmonary specifically or advanced bronchoscopy. So we'll talk more about that later, but since we did have Dr. Gupta here, I did want to draw on her experience and Dr. Bawaadam's experience, and just see how they would describe their practice pattern. What is a typical week for you, Dr. Bawaadam? What is a typical week for you, Dr. Gupta?
I'm going to say hi, Vritti, for joining us, and I'm going to let Vritti take the center stage first.
Sure, thank you. For those that are with us, my name is Vritti Gupta. I am an assistant professor of medicine with Wayne State University. and the Associate Director for our lung cancer screening program here at Henry Ford. I currently work as an advanced bronchoscopist here. And so my typical, I guess my work schedule is split evenly between pulmonary clinic, ICU rounding, and then time spent in the bronchoscopy suite. So for me here at Henry Ford, I'm fortunate to be at a very high volume center. We have a separate designated bronchoscopy suite, different from, our endoscopy suite for GI. And so for us, we typically have 2 bronchoscopy suite staff on any given day. And we have anywhere from, 6 to 10 patients scheduled for things like airway exams or transplant bronchoscopies, and advanced diagnostics like robotic procedures and EBIS TBNAs. So depending on what's scheduled in the bronchoscopy suite, I dabble in a little bit of everything.
So very similar to what Husam and Sevak mentioned here. I started my career after a Pulm Critical Care Medicine Fellowship from SLU and worked as a Pulm Crit attending a small community bed hospital, which is a 100-bed hospital in Kenosha, Wisconsin. I got to dabble my feet into everything, a little bit of EBIS, a little bit of navigation. But with one case of a massive bleed, I had to call IR as a backup. I soon realized, and I always thought about doing IP fellowship, even with my colleague, Dr. Setu Patolia, who's high up in the IP board and currently the program director at SLU, St. Louis University. We were in the same batch, and he frequently talked about it, and he pursued it, and I did not. There were other family limitations from my end that I had to come back to hometown Chicago, start a family, and then just got into the daily, call it chaos or call it chores. And that took a backseat. But I always had that at the back of my mind to do NIP fellowship. So fast forward 4 or 5 years later, I felt very honestly that at a community program, what Husam and Sevak said, where I have no other backing, I don't even have a thoracic surgeon on site. I have one IR guy who was there for absolutely from 8 to 3. And I'm fortunate that my bleeding episode happened around his time, and he was able to bail me out with a stat in geography and embolization, and the patient lived. So I soon realized that if I continued to do POMCRIT, it would be more and more years out. It would be harder for me from a community setting without much of research experience to go back to IP fellowship. And it's getting harder to match. And I'll be very honest with that. Although there are a rising number of programs coming up, close to 35 or 40 now, it's still about 1 fellow per program. So I soon realized I got into a few research opportunities that were available at St. Luke's Hospital, which is an academic center and a sister hospital up in Milwaukee. Got a few publications to my name and showed a keen interest back again, and very fortunate to have matched into an IP fellowship. And I'll tell you, that decision worked out very well for me, because coming back to the same hospital where I was for about 6, almost 7 years before going back to fellowship, there was no other POMCRIT guy. I was the only POMCRIT guy for almost 7 years, with ICU, pulmonary, reading PFTs and methacholine challenges, and doing all of it. So coming back, we wanted to have a team. And now we are a team of 4, where I'm an IP guy. We have a POM hypertension POM guy. We have 1 crit POM guy and 1 POM sleep guy. So everyone has their fair share of doing stuff in a 100-bed community hospital. And I'm able to expand this program forward to my community in Kenosha, which is Southeast Wisconsin and Northern Illinois, and do everything that an IP guy would do. And honestly, from what Vritti said, they have 2 endoscopy rooms at a place like Henry Ford. I have 1 endoscopy room, soon to have a hybrid IP, positive and negative pressure IP suite coming up July 1st that they built specifically for us. But we have about 6 or 7 bronchoscopy cases a day at a community hospital, which is a 100-bed hospital, including EBUSs, cryobiopsies, therapeutic debulkings, robotic bronchoscopies, and everything. So again, to answer your question, my day-to-day practice, I have to do everything here at this community hospital. I do 1 week out of 4 weeks of ICU, which are 4 of us, and the remaining 3 weeks, I do pulmonary and IP. And how I do it is every Monday and Wednesday, are my pulmonary clinics and my lung nodule clinics that I weed out the patients and see who's needing what. And every Tuesday to Thursday, and today was my IP day, Tuesday and Thursday from 7 a.m. until 5 p.m. are my IP procedure days. So that's how it pans out at my place. And every Friday is an add-on bronch day for me if I need to do it, / tumor board / admin day. So that's my day-to-day to answer your question, Danish.
Well, I think that's great. I think, this brings up a very important point. And before I forget, I do want to encourage all our attendees to ask questions as they come up, because this is really a forum for you guys to really ask the burning questions you have. And you can do that anonymously through the dialog box, or you can do it by raising your hand, whatever works best for you guys. And we really want to be here for that. I think what I'm getting from all four of you guys is that there was something you were envisioning regarding your future career life, and that kind of led you each to pursue the path that you guys have pursued. And I wanted to talk about the tension, if there may be, between doing what you guys are doing right now versus feeling, hey, did I miss out on pulmonary critical care? Because I feel that sometimes that I'm doing a lot of IP and I don't get to do as much critical care or pulmonary as I used to do. Or on the other hand, hey, am I doing pulmonary critical care and advanced bronchoscopy and I missed out on some of the other therapeutic stuff I wanted to do? So how did you guys reconcile that? And yeah, just want to get everyone's thoughts about that.
It's a tough question.
If I can take the lead on that, Danish, that's a great question. I was faced with this dilemma when I came back as to did I want to do pure IP and POM or have my feet in ICU as well? That's a great question. And I had colleagues telling me that you would miss out on your ICU skills. You would kind of forget your ICU skills if you were not to do it for a while. And that's all true. And so I think after a hiatus, if you've had a long period where you've not done inpatient shifts or ICU shifts, you become too complacent with doing your IP role, and you may be busy with that, but hard to fill in back. So I decided, I was given the option of doing only POM IP at this place because there were other guys who were willing to pick up critical care shifts. But I continued to maintain doing inpatient and ICU 1 in 4 weeks. That not only helps me continue to learn from my colleagues and from other team members and keep my critical care skills going, but it also helps me understand the criticality. It understands me to come to the rescue immediately when ICU things are needed. In ICU, there's a bleed or there's a bronchoscopy that's beyond any of the ICU staff to just put in an ambuscope or a glidoscope and do something that requires much more to be done. Also, it helps me pick up patients when they're being discharged from the inpatient side that otherwise would have been a simple nodule that would have probably been weeded out to a 6-month follow-up. And when they run it by me or when I'm doing the week, I'm like, this does not look, it's too good to be a benign nodule. Let me get another scan in a month after I've done the steroid and the antibiotic course. And those are patients that are probably coming back to me in the lung nodule clinic. So these are missed opportunities of early stage cancers that I've caught many a times in the last 2 years. So I feel, although it is hard to do the 1 week of ICU and continue IP and POM, I think it helps me maintain my balance and continue all of it, giving good justice and helping my colleagues out.
I think that's great, and I will echo that point, because when I first took a job out of training, I was doing mostly IP. It was really during COVID that I got back into the ICU, and since then I've kept a presence in the ICU, and I really, it was, obviously we don't need to talk about it, but it was a tough time, and we've gotten, we are where we are right now, and I feel that I am always thankful whenever I am in the ICU. This week is also happens to be my ICU week as well, along with Dr. Gupta. So there's always a different energy in the ICU, and I always enjoyed that as well. What about the rest of the panel? Do you guys have any? Do you guys ever think about something you missed out on, or do you guys think you have found a happy medium where you will be able to pursue what is important for you?
Danish, I'll talk about that. The last 4 or 5 years, I did a lot of ICU. Like sometimes every third week, every second week. It depends on who is available. So I'm thinking about the IP or advanced bronchoscopy as a specialty is a supplement. It's not substituting anything. It's just another skill set that you learn. You can learn through a dedicated fellowship, or you can learn when you practice with your colleagues who has the skills and the institution that provides the opportunity to learn. But I don't think if you are going in the path being an interventional pulmonologist or advanced bronchoscopist, proceduralist, that replaces or kind of, it's up to you. I think that's the good thing about this. It's up to you what you want to do. And actually doing ICU makes you more, I would say, more marketable in the job market. Because not all the hospitals, you know, guys better than me, you practice IP for the last several years. Not all the hospitals, they provide pure kind of IP job that you go to the endosuite from the 8 to 5 p.m. every day. No, you need to do some other things. I think for me personally, I don't think I need to give up the ICU to have a more IP time. Again, financially, it's still profitable to do some ICUs. I believe I heard from my colleagues, even in the tertiary centers, they do some ICU shifts. Maybe not every month, but they do every other month. They do like in a year, they do 5, 6 like ICU shifts. And again, it's about working with the team and getting more money. If you don't have enough volume for your IP like a career, you can supplement that with ICU, or you can split like a half and half. You can do like a half ICU and half IP. I think that's the beauty of this new specialty, that it just gives you opportunity to expand. And then at some point, you decide which way you want to go. I think it all depends what you want to do. And again, it's different settings. Yes, ICU like settings, it's a different lifestyle. IP, it's a little bit different. Pulmonary is different. I think the mix of all these makes you give you some rest, puts you in a different like a mode. I think it's nice to have different skill sets and practice as a kind of different doctor in different settings. So that's my take on this.
That's great. Go ahead, Dr. Gupta.
I think what Sevak said is a really good point, that IP skill set both lends itself well to the ICU setting as well as pulmonary, right? Because we're reviewing CT scans, we're deciding what procedure is appropriate for the patient. And that comes from our knowledge of pulmonary, whether we think this is infectious, whether we think this is malignancy. And then, of course, our bronchoscopy cases sometimes can be acute, high-level care of patients where, you know, they're hypoxic post-procedure. How do you manage their airway? So I think having that ICU skill set is good critical skills to have for the purposes of bronchoscopy or IP. And I think it lends itself well to general pulmonary practice as well, and trying to create a broad differential kind of using our pulmonary skills. So it's a good combination of both sides.
Great. I did see a question, Dr. Sethi. I saw that you had your hand raised. Wanted to give you the opportunity. We can go ahead and unmute you.
If you're not seeing the unmuted, feel free to throw in your questions into the chat or into the question feature. The software might not allow you to grant access to it, so feel free to type them in as well.
Okay, so while we are working on that, I did have a question for Dr. Nayef. So since you are the one who has looked for the job most recently, I wanted to kind of get you to talk about how you felt going through the process, how you felt you were received by your prospective employers when you had this desire to do either hybrid role or an advanced bronchoscopist role. How did that work out for you, and how was the job market for you overall?
Yeah, well, honestly, that was sort of what I was thinking about when you asked that question to the panel, because I feel that this is a huge part of how do you navigate this career path, because you want to fill in when there's need. And I think the job search for interventional or for advanced bronchoscopy is going to be a bit more challenging, because now you are more specialized and you have set up skills that you want to utilize. And then to utilize this to the best, you want to be where you're needed the most. I don't know. I mean, I think it's well received overall that you're able to do certain procedures, but I think it's more important to you to find a place where you're able to perform the procedures or the things that you want to do while still maintaining that good balance that is perfect for you. So I'm sure when Vritti was looking for jobs after she was closer to get training, I mean, she considered options and found the best thing that allowed her to do the critical care that she wants to do, the percentage of that, the percentage of pulmonary inpatient versus outpatient. And then in addition to all of that, you have to see, what is this hospital that you're going to join, or hospitals you're going to join, what type of equipment they have, and what type of role bronchoscopists have, because you oftentimes will be interviewed, and I've had my share of interviews, and when I've dug into the details, I found either IR gets all the nodules, or thoracic surgery is doing EVIS on patients, and for you as a new employee and coming in and trying to change that, it really takes a lot of effort. So
Can you hear me?
Yes.
All right, so I see some questions in the dialog box, so those are very good points, Dr. Nayef, and we'll get back to it, especially talking about how tough it is as a junior attending to come in and change the culture. But I did want to give the option for Dr. Sethi, if you still had a question. I saw your hand up, and then we have some other questions as well. And if you can,
Hi,
sorry, go ahead.
hi, can you guys hear me?
Yes, we can.
Hi, thanks for this presentation. I had a question, like some people like us, like I've been out of fellowship for almost 10 going to 11 years now, right? And I'm interested more in the diagnostics rather than the therapeutic bronchoscopy. I was wondering if there are any courses like a 6-week course or 1-month course at any of the university settings that we can avail to and get some, robotic bronchoscopies and EBUSs under our belt. Because sometimes it's hard to go back to fellowship after a couple of years because of different family reasons. So I was wondering if there are any courses that we can apply to, which is like an accelerated course, like a 6-week or 8 weeks or a month course that you guys are aware of, where we can get the skill set, at least for the diagnostics part of it, not the therapeutic part.
I will give the panel the opportunity if they have any thoughts about that. If not, I can take that question. So I think it is difficult outside of fellowship. There are obviously many fellowships that that are available with at multiple tertiary programs, where as a fellow you can go in and do a outside mini fellowship. There are some places that will offer a advanced bronchoscopy seminar, and usually that's more of a weekend that's more of a weekend seminar rather than a 6-week seminar. So I am not aware of something that is a 6 weeks course for someone who's out of fellowship. But I will let some of the other group talk about some of the other options that may be available.
So there is a chest EBIS course that happens every year at the Glenview headquarters, and that is a 2-day course. Similarly, there's a chest tube course that chest organizes at its Glenview headquarters in Illinois. So that's something, Dr. Seti, that you could avail of from an advanced EBIS or other pleural procedure standpoint. With regards to diagnostics that you're asking about, all advanced bronchoscopists can now do all platform diagnostics. If you were to get the Monarch robotic platform, you would have the Monarch people flying you out to California, taking you out to Atlanta, training you on site, taking you to an observation site. Similarly, I have the Ion Intuitive platform. If you were to get an Ion robotic system at your place, be rest assured that they would have you proctored for the first 25 cases by a rep standing right there. You would have a proctor coming to your place for the first 4 or 5 cases. You would be flown into Atlanta or Sunnyvale, headquarters, where they have the simulation lab to kind of equip you and to know the technical know-hows. And that is enough. It's always a 20-25 procedure learning curve. So that takes care of all your diagnostics. That takes care of your, there's a radial ultrasound course that CHEST organizes as well for advanced. And also, besides that, we have these workshops that are before ATS, before SCCM, before AA VIP happening in August in Chicago. We have the CHEST Hawaii coming up that has a 2-day course in advanced EBIS, radial ultrasound, diagnostic bronchoscopies, and different platforms. Besides that, Cleveland Clinic recently organized a course in Florida, and I was able to get those details. It was a 3-day course, which was on BLVR. So BLVR, there are courses held by, Vritti can talk to you more about it. Javier Mendoza talks about BLVR, does webinars on BLVR. Jonathan Kerman from Freighter Hospital has his sessions on BLVR as well. So these are some of the things that is both across the IP as well as the advanced bronchoscopist realm that are easily achievable, in my opinion. I don't know if anybody else has anything that I missed out on.
I did want to have Dr. Mercado join as well, one of our SAB board members.
Hi, everybody. Thank you so much for letting me talk. I'm at NYU New York, and this is great that you guys are sharing this because I had to go through very similar. We'll let it for another webinar what I did, but there is an advanced bronchoscopy course in Boston led by Dr. Hasnain Bawaadam, and he actually trains some of my fellows, in pulmonary fellows, that like the doctor was asking, that don't want to really go through in a whole interventional fellowship a whole year because they really are focused on diagnostics. And it's, I believe, between 6 weeks and 3 months. When you go to Boston, obviously you have to apply, but he's also interested in kind of like expanding that type of experience. So we may be replicating that in other, academic medical centers for people like, again, you don't have to go through a whole IP fellowship. Not everybody wants to do RIGs, not everybody wants to do therapeutics, but they all also want to be better at, some places are not getting exposed, some fellows are not getting exposed as they would like for these advanced bronchoscopy techniques, especially if they have an IP fellowship in the hospital. The IP fellow takes most cases. I'm sure you're familiar with that experience, and pulmonary fellows are kind of like complaining. But again, if somebody wants to expand that, they can look into that, and hopefully in the future we'll have more available.
I think that Dr. Mercado, I think that's a good point, because personally, I went to the different institution last year for three weeks of IP kind of rotation as a second fellow. That's, again, when you go for that type of rotation, you cannot pick and choose. You just need to go with the flow and whatever comes, and you can get some exposure to that. I think that's a one opportunity. A lot of institutions, even if they don't have a formal rotation external from outside, I think a lot of tertiary centers, especially when they have a IP fellowship, they are open to that. I think if someone is really interested, they can reach out to the program director and see if they offer that kind of things. That's helping for the current IP fellow too, and that's good for the institution because they want to have a recognition that they accept outside people, and they kind of also do some they can pick and choose which fellow is good, and they're happy to help. I think that's another opportunity. If that's not a 3 or 4 day course, but that's something that if someone can dedicate 3 weeks, 4 weeks, or 8 weeks of their time to, they can learn a lot of procedures with that way.
All good points, and thank you, Dr. Mercado, for joining us on this webinar. I would make a point with what Dr. Bawaadam said, and that's very true. If you do end up purchasing a robotic system, then they will be there to support you. So, and if there's any, so one of the things about IP is that there are a lot of technologies that are coming out. So I would always caution everyone that not to just jump in and get a technology unless you feel that the vendor is there to support you as well. So it's not, this relationship is not just buying a product and that's it. With any of these new technologies, whether it's a robotic platform or anything else, you always want to make sure that the vendor is there to support you, because that is an integral part of advanced bronchoscopy. So I always want to make sure that people are aware of that. We had another question here that I wanted to get the panel's thoughts on. The question was, what are the footsteps that you use to get a job in interventional pulmonology or pursue a career in interventional pulmonology versus advanced bronchoscopy? Did you guys follow through and go through a different track, or was it the same track? Can you guys hear me?
Yes.
Okay, well, I can take this one. So I will say the first thing that you want to think about when you're pursuing either advanced bronchoscopy or advanced bronchoscopy is think about really what you're interested in, because the term thoracic oncology is very poignant here. I think when you're becoming either advanced bronchoscopist or an interventional pulmonologist, that's really the pathway you're going down. So you start to work in a multidisciplinary team, and you start to attend tumor boards, you start to look at lung nodules, start to look at pleural effusions, you become integral part of the thoracic oncology team. So the footstep that I looked into was really started attending tumor board more often, really spend time with the interventional pulmonologist that was in my fellowship, saw what kind of cases they were doing, and then also pursued some research that showed my interest. So, you know, some of the regular stuff that we do for most of the positions that we're interested in, you know, show interest, be there, really try to understand the day-to-day working of it, and go from there. All right.
So I would say if you are in a fellowship and you want to kind of decide if you want to be proceduralist, interventional pulmonologist, some fellowships, they have a kind of mandatory rotation in IP. Some of them they provide as like elective. If it's elective, I will encourage guys to go for that rotations, because that's gonna kind of give you idea what to expect, and it's a starting point. For example, during my fellowship, I was lucky to have a IP attending, and And I basically started doing this elective rotation. I did like I think 3-4 months of like IP rotation during my Palm Critical Care Fellowship. I know some places it's a mandatory, you need to go. Some places they just offer you, and some people they don't want to do it and they don't go. I think that's the first step. Of course, Danish mentioned the interest, starting the research. The research shouldn't be like a big thing. You can start with the interesting case reports and try to present in the national or international conferences and to know the people. And it's a small community, I would say. It's expanding, but you need to know the main like topics, the hot topics. Every 6 months there's a new hot topic in advanced bronchoscopy, and it's developing like pretty fast. During my fellowship, there was no robotic bronchoscopy. Now, after like 4 years, 5 years, there's a new technology that everyone wants to go. I think just showing the interest, being active, doing procedures, kind of trying to publish interesting cases, and being there with your advanced bronchoscopies, that's the first step for me. It was like that.
And I think if you're in a fellowship program where there's no separate, bronchoscopy rotation or IP fellowship, it's important to seek out a program where they do offer that, so you can rotate with them, especially now that I know during the pandemic that was difficult. Now I think rotations are opening up more for outside rotators. So I think that gives you a good idea of what the field of IP is and how that's different from advanced bronchoscopy and all of the different procedures that are a possibility in this field. So it's important to just have an idea of what IP even entails,
All right, that's great. I did have a question, but I wanted to go back to one of the questions in the chat. The question is, what's the difference financially after IP fellowship versus doing pulmonary critical care? So more of a numbers question here. I think we can talk, we don't have to be super specific, but in general, I can start. I don't think there is a big delta between the two. As Dr. Keshishyan mentioned, critical care in general is highly reimbursable. So when you do pulmonary critical care, you generally do get the RVUs and are able to financially get those gains. So I don't think doing IP fellowship helps you increase your pay dramatically. There's some places if you go in and become a director of a program, then that's a different ball game. So if you're becoming a director of a program and that's coming with the title and other responsibilities, things may be different. I wanted to get everyone else's thoughts as well. I guess I'll start with Dr. Bawaadam here.
Thanks, Danish. You said it correctly. So every physician in my group who's a PalmCrit board certified and me being PalmCrit IP, there is no difference in the pay package. That stands out. Yes, there's a small amount for a director of bronchoscopy division that you get paid, not much. But I think what may stand out a bit, but again, you tend to lose out on your critical care, is some of the procedures that you do during your time have a higher RVU associated with that. So if you're on a guarantee, and I'm talking this primarily from the Advocate Aurora standpoint, which is a close to 29 hospital system across Illinois and Wisconsin, they have all pulmonologists on a base, and anything above that is paid as a supplement based on the RVUs that you make. So if you were to do 8 or 10 bronchoscopic procedures in a week, would certainly add to your RVU tiers and build up. Now, again, that being said, does my sleep guy read a lot of sleep studies and home sleep studies that kind of equates to the same RVUs at the end of the year? Yes. Does my pulmonary hypertension guy do more ICU shifts when he's not doing pulmonary hypertension, equates to the same or maybe a little more than me? Absolutely. So if you're going to do IP, thinking about a better reimbursement package, that is not the way to go. And if you have colleagues, like if you would have an academic center who would hone your skills and kind of segue you back into an IP and advanced bronchoscopy role where you can do everything and also do Palm and Crit and read a few sleep studies, that would be the ideal thing to do. But at a center like mine, where you don't have someone to mentor you, and you're the only IP guy to kind of take on the role of doing this for the community, then you take that with the responsibility that you're doing IP to help the community, not for a financial package.
I think I'll second that. I think most of us are on the same page. I think if you're doing advanced bronchoscopy or interventional pulmonology, it's because you enjoy what you do, and you also enjoy kind of, you know, taking care of the disease process. But I don't think it really makes a difference in your pay package. I did have one question for Dr. Nayef and Dr. Gupta. This kind of goes back to something we spoke about earlier. So, you know, you become a part of a group, and Dr. Nayef may have a different experience than Dr. Gupta, depending on the location you're working at, where not everyone is an advanced bronchoscopist and not everyone is an interventional pulmonologist. You know, your colleagues at pulmonary critical care or sleep or PH or ILD group, ILD personalities. So how do you guys, is there a tension for you guys when some of them may feel that, hey, you should be in the clinic just as much as us while you're in the bronchoscopy suite? How do you kind of get your colleagues to understand what you're really doing and what value you're bringing to the practice as a whole, and also for the patients that we're serving?
So I think for Henry Ford specifically, we have a lot of subspecialties here, and within subspecialties, we have 2 to 3 staff that are there. I think that makes it a better work environment for us in the sense that as an advanced bronchoscopist or as an IP physician, all of the procedures that may or may not need to be done get routed to us, and all of the other providers kind of have that understanding that if someone needs a bronchoscopy, they need a diagnostic robotic bronchoscopy, they all get funneled to the IP advanced bronchoscopy group. Even amongst the transplant, you know, patients that need their surveillance bronchoscopies, they all come through us. So they understand that someone needs to be in the bronchoscopy suite. And apart from that, we do have our pulmonary clinic. We all still do critical care time. So I don't think it takes away from the time that's spent outside of the bronchoscopy suite, because the other subspecialties are also spending the same amount of time, you know, in their own subspecialty clinics or their own kind of ICU rounding time. So I think it evens out in that way for us. I don't know that there's much tension here from that standpoint, which is it makes for a good work environment for me.
Yeah, I mean, I think kind of being firsthand observer of the IP physician who works at a private hospital environment, and yes, there is a fellowship, but it's still a private group. So, and then that's kind of going to be similar to the background and environment. That's going to be my background and environment. I think there has to be a buy-in from the partners and the people in the group that the patient does need the procedure. The patient does need the diagnosis, and oftentimes you're going to have the diagnosis and the staging at one procedure rather than exposing the patient to 2 anesthesia and having other departments take care of that. So the question is, do you want the patient to go somewhere else, or do you want to just, have somebody that's there available to do it? And I think that understanding comes into that when you have somebody who's sort of available, 5 days a week to kind of take on those procedures as they come, there is going to be some limitation of the time that they're going to be able to do their clinical duties. So it is a challenge. I'm sure that I'm going to have to figure that out throughout the way, but I think having the understanding and the buy-in from the other partners who are available to kind of see an extra consult at 3 p.m. or something while you're in the bronchoscopy is the only key to really be able to do what you do. And I think the better way to do it for future fellows is to have that conversation right from the beginning when you're, kind of interviewing for the job.
Sorry, guys, I was muted. But I think that's very good advice, Dr. Nayef, not just for IP, but for looking for a job in general. Really try to understand what your responsibilities will be and make sure the group understands what you're bringing to the position. So we're getting up closer to the end of the hour. So I just want to make sure if people had any last minute questions, feel free to put it in the chat and we'll try to get to it. At the same time, I do want to let all the fellows know that we highly encourage all of you guys to join the SAB, Society for Advanced Bronchoscopy. This membership for fellows is completely complimentary. We want to be a resource for you guys here, and we want to amplify any questions, concerns you guys may have, and we want to do more of this kind of stuff, just reaching out to you, spending some time with you. In the future, we'll be doing some more stuff specifically aimed towards fellows. We have a new webinar that we'll be doing periodically. It will be called Fellows Corner, and where we'll talk about interesting cases. I'm going to have Dr. Keshishyan just say a couple of sentences about it, and then if no other questions, then we will say good evening and thank you for joining us.
Thank you, Danish. Yes, as you mentioned, we encourage the fellows to be a member because that's the kind of first step. We're talking about the first step of what you wanna, how you decide on how you get involved. I think you just need to be a member of the society and kind of get the sense what you want to do. And as Danish mentioned, we want to kind of involve the Pulm Critical Care Fellows, and we're gonna, in the upcoming months, we're gonna create the Fellows Corner that we can accept that interesting case presentations, which involves new diagnostic procedure or unexpected side effects or like unexpected course of disease, which involves advanced diagnostic procedure, and give you guys opportunity to present in our like a live webinar. That's gonna be kind of help you to get involved in the society, also in the field in advanced bronchoscopy and interventional pulmonology. So we're gonna post in upcoming weeks or month about this in our website. Thank you.
I think that's excellent, and there's a question to that effect about if a recording of the webinar will be available, and I think that's a very good question by one of the attendees, because really this webinar is available to everyone who's a member. So it is behind a wall, but for all members, this is available. And as well as every other webinar that the Education Committee hosts, we make those all available to our members. So even more reason for fellows to join and make use of that resource. So at this point, I just want to end and say thank you to Dr. Bawaadam, Dr. Nayef, Dr. Keshishyan, and Dr. Gupta for an excellent discussion. I really enjoyed it, and I hope you guys enjoyed it as well. Have a good night, everyone.
Thank you.
Have a good night. Thank you.
Good night, everyone.
Good night.
I didn't get that. Could you try again?